Good morning, everyone. I'd like to thank Dr. Verma for this opportunity. So I'll be speaking upon the broad principles of diabetic macular edema management with anti VEGFs. It's not playing. Okay. So the principles of DME therapy, primarily first to address is metabolic control of the patient. Look at these, investigate, address these, and then start local treatment, which is primarily serial anti-VEGF injections, which are the first line ocular therapy. Laser, steroid, intravitreal steroids, and vitrectomy have secondary roles in particular cases. So what is metabolic control? It's control of these 5 main factors: glucose, blood pressure, serum lipids, anemia, and renal status. And if these are addressed, improvement can be seen as early as 4 to 6 weeks, even without injections. At the same time, if the edema is significant, the local treatment also starts. DME can be center involving or non-center involving. In the center involving, if the vision is not affected, patient is asymptomatic, and the edema is not severe, foveal contour is nearly normal, you can just observe. If the vision is poorer than 20/32 and the edema is significant, only then injections should be started. For non-center involving DME, there is no role for injections and only laser can be offered. So this is the whole host of anti-VEGF injections and the 2 steroids that are available. The anti-VEGFs remain the first line of therapy as per American, European, Asian Retina Society guidelines for DME management. They not only take care of the macular edema, but they also reduce the diabetic retinopathy severity score so that they take care of the proliferative aspect. Steroids can also be used, but the problem is the raised IOP in a large proportion of patients, cataract in phakic patients, anterior migration if there is a large PC opening, and increased risk of infections in the immunocompromised, which diabetics are immunocompromised. Other limitation of intravitreal steroids, which is not much spoken about, is they are not as good in their visual and anatomical efficacy compared to the newer anti-VEGFs, which was already listed, aflibercept or faricimab. Even when the anatomic response can be similar, the visual result is often inferior to the newer anti-VEGFs, which I have repeatedly seen that even if there is an anatomic response, you can see the vision has actually deteriorated. Now, this has been commented on in many papers, but the reason for this is not really known. However, the patient is definitely more satisfied after an anti-VEGF compared to a steroid injection. So these were the studies in 2008 which showed that there could be more than 10-letter gain with monthly injections of ranibizumab. And then came the VISTA and VIVID in 2015, which showed that instead of monthly, you could give once in 2 months aflibercept injections, and that is as effective as giving it monthly. So that reduced the treatment burden. Now, what is the current guideline on management of mild edema where the vision is good, patient is asymptomatic? Nothing should be done. When aflibercept with laser and observation, these 3 were compared, there was no difference in outcome at 2 years. So if we start treating these patients, we have been over-treating. Just review them periodically and treat if there is a worsening. So this is how now we treat, no intervention, and the patient has resolved spontaneously in 2 years. Once we decide to treat because vision is poor, then the protocol is to give 6 monthly anti-VEGF injections, and at the 6th month, offer laser for the persistent edema. Now, how long should you continue the injections? The injections can continue if there is any improvement compared to the last 2 injections. Stop if it remains stable over the last 2 injections, and restart if there is any worsening compared to the last 2 injections. But please note that presence of fluid is not an indication for continuing injections. Now, worsening or improvement means 5-letter change or a 10% central subfield thickness change on OCT. Now, why 6 injections and not just 3 injections? Because at 3 injections, 52% of the eyes still have persistent edema, whereas by the 6th injection, this number has reduced to 32%. Now, which anti-VEGF to choose? In the overall group of patients, all anti-VEGFs, aflibercept and ranibizumab, were similar. But when the vision is lower than 20/50, which means severe diabetic macular edema, At 1 year time, aflibercept gave a speedier and significantly better, statistically more significant improvement in vision. But by 2 years, the difference between aflibercept and ranibizumab was not statistically significant, even though it was, aflibercept still had better visual gain. And the aflibercept continued to remain superior to bevacizumab at all time points. How promptly should the treatment start? Treatment should not be delayed for months to years, because when there is a prompt treatment was given, it was seen there was an 11 letters gain with all, ranibizumab or with aflibercept. But when there is a 2-year delay, despite monthly injections, the gain is only 4.5 letters. So prompt treatment is important to prevent permanent damage. Role of macular laser, the drcr.net confirms that laser is very effective. It causes improvement beyond 16 weeks without any additional injections. And there is no difference whether it is done promptly at the first presentation or as a deferred treatment after 6 months. Now, what was it is offered for persistent DME at 6 months of anti VEGF after 6 months. And what is the percentage of eyes that require laser? With aflibercept, only 41% have persistent DME, whereas with Avastin, 64%, and ranibizumab is intermediate. Additional lasers can be done if required. Fluorescein angiogram to identify the microaneurysms and treat these. Most of the injections are required only in the first year, and almost no injections are required after the 3rd year. Hard exudates are more damaging and also more difficult to take care of. You can see they can progress very rapidly within a month. So these need more intensive treatment. This was a patient where it started resolving with an aflibercept, but patient was lost to follow-up for a few months, came back with significant increase. Again, we were able to treat her and get her to very minimal exudates. But again started increasing because her lipids were very high and diabetes became uncontrolled. So both the things are important, metabolic control and injections. So finally we were able to get down everything. So this is to show that anti-VEGFs work very well for hard exudates. You don't need steroids for hard exudates, and also metabolic control is also enough. There is no injection given in this patient, but the inferonasal exudates have resolved. So metabolic and lipid control are crucial for hard exudates. Injections are not effective if this is not taken care of. Newer potent anti-VEGF agents are effective for hard exudates without the adverse effect of steroids, and steroid is not default therapy for hard exudates. Exudates and edema may respond differently, and they don't always happen simultaneously. Though exudates may need more intensive therapy with injections initially, and long treatment intervals can allow progression, and close follow-up is required initially to monitor for recurrence. Peripheral laser to non-perfusion areas is being found to be not effective for the management of DME. Even post-vitrectomy, the newer anti-VEGFs, at least aflibercept, has been studied, and it has an equally good effect as if it's a non-vitrectomized eye. Post-vitrectomy, when we give steroid for the DME, there is a steroid response sometimes, and then when you switch to aflibercept, I found that there was no difference in efficacy and duration of action. An important concept in DME can be that if you have treated one eye, the other eye can respond very well. So always check the other eye before you give an injection in the other eye after a few days. Sometimes it's not necessary because of the systemic absorption. So when to consider steroids? When anti-VEGF is contraindicated, as in pregnancy, recent cardiovascular events, renal dysfunction, and when there is a traction with active neovascularization, which can get worse with anti-VEGF. But steroids has to be avoided even in those situations, in the presence of glaucoma, immunocompromised patient, posterior capsule is absent. And lastly, what is the role of topical NSAID drops for the management of DME? It was found in the drcr.net to not have any significant change in vision, anatomy, or progression to center involving DME compared to sham. Thank you.
Thank you, Mallika, for this very, very crisp kind of presentation. We will have, after every talk, 5-minute discussion, because I don't believe that discussion at the end is relevant. So anybody would treat differently than what Dr. Mallika has said about because only thing which I could gather was she is dead against steroids. She does not use...
I could not get your question, sir.
No question, but just a comment. I was just asking the delegates and the learned people sitting here that anybody would do differently than what Mallika has presented. Yes,
Hi, Dr. Rahman, great presentation. So you have mentioned that you should be seeing the contralateral eye as well, after seeing one injection. So, what is the evidence that we have for that? How often do you do that? Because for me, we published one paper on the contralateral effect of Ozurdex long back, but I think we were wrong in that sense because the systemic exit is too low to give any kind of impact on the other eye. That's what I feel. So that's the reason that DME we say that bilateral therapy is needed. So I just wanted to have more clarity on that.
No, you're right. Bilateral therapy is needed and we give most often. But there are those occasional surprises where if you have spaced the two eyes by 5 days or 7 days or even 10 days and then you just do a screening of the scan before you treat the second eye, you find that that has also resolved significantly, patient has improved significantly and is no longer interested in the injection. And probably you don't want to give even because the vision is 6.9, 6.6, so you may not want to give, you can wait.
Do you think that has a more relationship with the systemic parameters?
No, I don't think so. In 5 days, I don't think so. 5 days will not make sense.
So, no,
it's an anecdotal
some
effect,
observation has been there, some observation, few reports are there, but to call it, it's not a very common finding, not a very common observation that other eye, if it's a month issue, then, what Ashish said is okay, but 5-7 days of observation, if it shows, what is the mechanism, do you think, that systemic absorption and then coming into the eye?
Yes. And that is how systemic absorption is definitely there enough to cause
side effects.
Kidney, renal injury, cause cardiovascular events. So how can it not affect the other eye?
Actually, another proposed mechanism is transchiasmal flow. Part of the transchiasmal flow also. So it's anecdotal. It's not proved as a regular this thing.
Absolutely.
At the same time, supposing a patient says, I've become better,
Yes.
before you inject, you might as well check him out.
Yes.
That's all. It's just, you don't need it in every patient, but in a patient who says, I've become better in my other eye, before you inject him in that eye, check it out.
Yes, sir.
I have a more practical question. Most of the time, the diabetic patients have uncontrolled diabetes. So do you differ the injections? Do you have a cutoff margin for diabetic patients that in this point I will not give injection in this diabetic status or any guideline?
So my take on this is both have to go parallel with each other. Unless there are, a lot of heart exudates there, which Mallika said, I would not like to wait because Mallika said prompt treatment, delayed treatment. Delayed treatment graph still picks up, but it never matches that original this thing. So both can go because diabetes is a lifelong disease. You have to, virtually threaten the patient if you don't control what is the purpose of giving injection. I tell them, I will give injection. If you don't control, you will have multiple injections all through your life. Although statistically, Mallika said maximum injection is required in first year, and then third year it virtually comes down to 1 or 2. But ultimately, metabolic control is what is important in
But Lalit, it's an important question from the point of view of medico-legal aspects, that when do you not give the injection?
Yeah, we are coming to that. I have not just finished. Yeah. So what I'm saying is, although the Government of India guidelines, the court of law, these judges and all, they will not understand. You go to American Academy and European people, I have questioned them also. They don't bother, even if you see the studies, HbA1c till 12. Even if blood sugar, I have questioned directly to them, same question which you are asking today me, I asked them, even if blood sugar is 400, they will not defer injection. Because blood sugar, you give insulin, it will come down. Immediately you give increase insulin to say 40, 60, it will come down. So you can be safe. But I am not denying that metabolic control has no relevance. It is of utmost importance. But a couple of days here and there you can delay, but you can't defer it for months. Yes.
So in the presence of PCR, you are saying in pseudophakic patients, do you think Ozurdex is absolutely contraindicated, or if you will give in a slightly different way, or just make sure that it doesn't come out into the anterior chamber?
Yeah, if there's a very large opening, let's say scleral fixated IOLs are there where there is no PC at all, or FAK if at all. Well, I have seen it in a scleral fixated IOL where it has migrated and caused a corneal emergency, raised IOP, and then we had to remove it in emergency. So it is a contraindication. It's even in the package insert it is given, not to use it where there is an absent PC or a large opening. So you could even have medico-legal problems, in fact, because it's there in the package insert. So be careful. Be careful.
Fixated IOLs are different. Suppose routine pseudofakes, they have some PCR.
No, not that. Not a regular PC opening, but an large one. unusually large one.
Any other observation?